So thank you very much, Goran. That's great. I hope you can see the screen and the slides clearly. So I thought I'd just give 5 minutes on where we're at with EBC Main. Obviously, it's been, I think, a big success in terms of generating discussion. And just to remind people about the outcome with this study, it was 460 odd patients who went into the study, randomized to provisional versus a systematic dual stenting approach for bifurcation left main stem disease. And here are the 1-year results, which I think you know well, but I just reprise them very briefly to show essentially no statistical difference between the two groups at 1 year. Numerically more revascularization in the 2-stent group. Okay, so at the time, what were the conclusions that we had from this study? So firstly, we had numerically fewer serious adverse events with stepwise provisional. We had less use of consumables. Importantly, only 20% of patients in the provisional group required that second stent, even though all the cases, the operators were happy to put a second stent if they were randomized to 2 stents. So for me, the most important message of the study was that actually it's not necessary to prejudge the issue and start with what is a non-provisional and obligate 2-stent approach. So for me, that was the strongest message. Patients obviously equally well treated at 1 year with the stepwise layered provisional approach. So I think that leads to the open questions here. And there are a number. Firstly, why is that different to DK Crush 5? And I think we've already had the chance to discuss that a little bit in terms of the complexity of the patients anatomically, the length of the side branch disease, the what we might call the philosophy bias between the European and the Chinese camps, if you like, in terms of how to approach these patients. So there are a number of reasons for that. Of course, interestingly, will the outcome be maintained at 3 years? We've seen in previous studies some divergence of curves in favor of a less metal implant, a simpler approach over time with some of the studies that go back a decade. So that'll obviously be interesting. I think very importantly for the EBC, we have to change the perception that 2 stents in the provisional strategy is a bailout or a failure. It's not. It's the final common pathway of the stepwise layered provisional approach. And equally, how do we encourage people to have the resolve to start a complex case provisional? They often will look at it and go, well, that needs 2 stents. So they prejudge the issue and they don't necessarily have the courage. People think of provisional as a simpler approach, but it's not. It's a logical approach and it takes things step by step until you have a good result. That may be with 1 stent, maybe with 1 stent and a kiss, it may be with 2 stents. I think one of the things I sometimes hear is that people feel there's a clinical difference in outcomes between an upfront 2-stent strategy and a provisional technique that ends up with 2 stents. Now, I don't personally believe that's plausible, and I think that's selection bias in the non-randomized papers that allude to that. But it's a perception which we have to address. And then, when is disease sufficiently complex that 2 stents are fundamentally inevitable? Whether or not you decide to do a provisional or a dedicated, when is that point where the side branch or side vessel mandates stenting in its own right? For some reason, DK Crush, I mean, obviously the trials will be done, so I understand that, but there's a sense that DK Crush is a specific go-to 2-stent strategy. I think we have to challenge that and say, fundamentally, is there any real plausible reason to suppose that an optimally done DK Crush is systematically superior to an optimally done mini culotte? Personally, I don't think so. There's the question which everyone raises of, would the results be better with IVUS and OCT? This is a little bit like the surgeons sort of always saying, oh, well, yes, I always do bilateral internal mammary grafts. It's like us saying, oh, I always use IVUS. But actually in the clinical trial, you didn't always use IVUS. It was 35%. Would all the results be better systematically with IVUS? Is it clear to us? I'm not sure that it is. Is it clear to us what trials should be done next to help further the field?